Boom. All right. We have Taylor Goldberg here and Sam's here as well. Taylor, thanks for coming on.
Thanks for having me.
Yeah. Could you give us a little bit of an intro and a background on yourself?
Yeah. So I graduated chiropractic school about a year and a half ago now, which is pretty crazy. Went into an in-person practice and didn't have the greatest experience. And now I'm on my own and I'm a completely virtual hypermobility coach. And I work solely with the hypermobile population.
Nice. And do you want to go into a little bit about your own experience with the diagnosis?
Yeah, sure. So I actually have a very different story than most people. Most people who are trying to get a diagnosis of HEDS end up taking a really long time. I think the average is like 22 years or something crazy like that. And so I was lucky and got diagnosed really young because my mom was diagnosed. And so I was able to get support from a very young age, which I really, really think changed the trajectory of my life. And I'm very passionate about getting other people to be diagnosed younger. And I think that screening tools are a really good way to start, especially in certain sports where we know this is super, super common, like cheerleading, gymnastics, ice skating, swimming, dancing. And so because of my experience, I was able to pretty much be fully functional. I needed a couple extra supports as a kid mainly, but in my adult life, I've been pretty functional until I went to chiropractic school. And then getting adjusted a lot really did not do well for me. And so I ended up in a lot of pain and had some scary neurological stuff, which I know we're going to be talking about, upper cervical instability, which is what I did deal with. And because of that experience, I'm able to give kind of a different light to this topic.
Yeah. So the paper that you shared with Sam and myself just came out recently, a few months ago.
Yeah.
And like you had mentioned, it's covering this kind of consensus recommendations on upper cervical instability. But before we dive into it, do you want to have some working definitions for what is probably going to be talked about a lot, whether it's the hypermobility spectrum disorders, EDS, however many of these you want to start out with definitions, and then we can go into the paper?
Yeah, definitely. So EDS is Ehlers-Danlos syndrome, and there's multiple different types. What we're going to be talking about is the HEDS, so the hypermobile Ehlers-Danlos syndrome type, and that is the only one that doesn't have a genetic factor right now. So you can't get a blood test and it confirm that you have this. You actually get a blood test to confirm you don't have all the rest, and then you get a diagnosis of HEDS. And so HSD, which is hypermobile spectrum disorder, and HEDS right now are the same thing. That will be changing. Hopefully a gene is coming out really soon. For those of you who don't know what the Norris lab is or who Courtney is, she is working on figuring out the gene for HEDS, which is unbelievable. And I highly recommend checking out her work. She's really doing amazing things. And once that happens, there's going to be a whole different set of criteria. But for now, what we have to go with is what we have. And so in 2017, they created a diagnostic checklist. It's actually never been clinically studied, which I think is pretty interesting. And there's a lot of debate and opinions about it, but it is what we have to go with right now. So with the diagnostic checklist, basically there's 3 parts. The first part is the Baton scale, which most clinicians know by now. And if you pass the Baton scale, you move on to the second part, which is basically a list of systemic questions. You need 5 of the 12 of those systemic questions, and then you need to be in chronic pain, basically. You pass those 2, you get sent to a geneticist you can be sent to any doctor, but in my opinion, and from what I've seen, especially in the US, I know it's different in other countries, but in the US specifically, I really haven't seen anybody be able to do this except for with a geneticist. And I've also seen a lot of people waste a lot of time trying to find different doctors. You're better off just going to a geneticist at this point, in my opinion. And so then you go there to rule out all the other EDS types, any other connective tissue disorders like Marfan's, and even some autoimmune and rheumatoid arthritis. A lot of these can kind of mix. And so we want to make sure you're not dealing with any of those and you are actually dealing with HEDS. And then there's a lot of comorbidities that come with HEDS. And one of them is upper cervical instability, which I really like how this paper kind of just combined cranial cervical instability and atlantoaxial instability, because I think it can get confusing and it really doesn't matter in a conservative care setting at all. So just calling it upper cervical instability at this point, I think is a really good idea. They also talk about symptomatic general joint hypermobility. And so joint hypermobility can be asymptomatic or symptomatic. And I think that's really, really important. And I know we're going to talk a little bit about over-medicalization. And I know that that is one thing, like asymptomatic hypermobility does exist. And you can use that to your advantage. And if you're not having symptoms, you don't need to kind of go down the same rabbit hole as someone who is having symptoms.
Nice. So this paper, I'll just read the title so people can kind of follow along if they want to, and I'll share it in the show notes. But it's by Leslie Russick et al., 2023. This was in, I think, Frontiers of Medicine. And it's titled Presentation and Physical Therapy Management of Upper Cervical Instability in Patients with Symptomatic Generalized Joint Hypermobility, an International Expert Consensus Recommendations. Do you want to give a big picture kind of overview of why you wanted to chat about this paper in particular, maybe some kind of big picture thoughts, and then we can maybe go through the paper?
Yeah. So the reason I even brought this paper up is because it's the first one. So we don't have any sort of guidelines. We don't have any sort of research on upper cervical instability in a physical therapy setting or in a conservative care setting. We have a couple of papers on symptoms and etiology, but we don't have any recommendations for even diagnosis and especially for care. And so I thought that this was kind of the first time I've seen upper cervical instability being talked about in a kind of formatted way that makes sense to me and other clinicians, and also just lays out a good way to kind of look at it from a different lens. Whereas in the general population, if someone comes in with neck pain and neurosymptoms and these scary type things, you usually are going to refer them. The issue with referring somebody with upper cervical instability is that there's nothing, they're going to get a brain scan and it's going to be clear. And then the neurologist is going to say, okay, there's nothing going on here. I don't know what to tell you. And I've seen that so often. And so I think it's really important that we all get on the same page with this and know that we need to also look at the cervical spine, and that the only way to diagnose this right now is through an upright MRI or a dynamic X-ray, which are really, really hard to find. So if patients are coming to you and they're saying, I think I have upper cervical instability, but I don't have a diagnosis because I can't get the imaging, that is valid. And I think we need to be okay with that and treat them as such.
I'm curious, before you head any further, Sam, have you worked with any patients with upper cervical instability or more broadly EDS?
No. Yeah. No, none on my radar.
Got it. Yeah, Taylor, she came on my podcast. It's like been 6 months at this point, but
I know,
my
crazy.
First girlfriend in high school and undergrad, she was diagnosed with EDS. And so it was interesting seeing her experiences. And then I've had a few patients in clinic with either hypermobility EDS or just generalized hypermobility disorders. So it's selfishly, I like these conversations because I feel like I know very little, and it's great hearing from someone who's has it and does a ton of research on it. So anyways, let's go into from there. Do you want to define even what like upper cervical instability is? And then I know they go into hypermobility, mechanical instability, and functional instability. Maybe we talk about those two.
Yeah, I actually thought that was really interesting that they added that in. So what upper cervical instability is your skull bone, and your, can you still hear me? Good. Your skull bone, your first cervical vertebra, and your second. And so any sort of laxity in any of those ligaments that hold those together and basically hold your head up, any laxity in that would be causing cervical instability. And that laxity can be caused from multiple different things. So it can be mechanical in nature. It can also be systemic. So there's now a lot of research being done on mast cell activation syndrome and showing how mast cells can actually produce more laxity in ligaments as well, which is a new kind of concept. And they're doing a lot of stuff with that with long COVID and things like that. So it's pretty interesting. And so with upper cervical instability, there becomes a risk of brainstem compression, which is where we get into those neurological symptoms and a bunch of other stuff. And the hard part is that POTS and dysautonomia comes very, very often with EDS, and the symptoms of dysautonomia and UCI cross all of the time. So trying to figure out, one, which one are we dealing with? Two, does it matter if we treat this as dysautonomia and you get better? Does it really matter? But if you don't, it might. And so that's kind of where they broke it down into like mild, moderate, and severe. And those severe cases, they're not going to get better from just treating this as if it was dysautonomia and neck pain. They're going to most likely, unfortunately, need some sort of surgical intervention and some other things. And so really figuring out how severe your patient is presenting is really important.
So we can dive into it in as much detail as we want, but maybe we chunk it into a few sections of this assessment or this initial examination process, and then those 3 levels of severity. And then maybe at the end, we talk about the interventions that they proposed, which I'm very curious to hear your thoughts about those as well.
Definitely. So I really liked that they mentioned that these patients are in pain and they are struggling. And if we are to do a physical exam right away on them, it might flare them up. And flare-ups in the general population may be pain for a couple of days. But unfortunately, in this population, it can get to the point where they can't leave bed for months. And so that's why it's really important that we get most of our information from the history and really ask questions and listen and see if this really is what we're dealing with. And do we need to do these physical exam findings that may flare them up? Or are they severe enough where we need to refer for an upright MRI or for a dynamic X-ray? And so really taking that into consideration before you start pressing down on somebody's neck who may be having brainstem compression, I think is really, really important. And we know that we can get most of our information from a history. So really learning what symptoms and what questions to ask when it comes to upper cervical instability. And so some of the things that I look for specifically, let's say you have someone that comes in, they're having headaches, maybe they're dizzy, maybe they're presenting very dysautonomia-like, and then asking, does it change going from sitting to standing and laying down to standing, or is it more changed when you're just sitting? Are your symptoms worse when you're looking down? Does it feel hard to hold your head up? This bobblehead sensation is used a lot, and I think that's a pretty good description. You literally feel like a bobblehead, like you can't hold your head up. You need support in order to feel comfortable. Sometimes people will say, oh, I put a pillow behind my head, or I have to sit in a way that gives my head support. That's always a red flag to me. And then also brain fog, but brain fog to the point of where you're truly forgetting things in important situations. Whereas brain fog usually is more of a general term, like in general, whereas with cervical instability, it's going to be a little bit more specific. So like I said before, it's hard to distinguish the two because they overlay a lot.
So if in let's say just a rehab provider in general, whether it's physical therapy or chiropractic, and a patient's coming in, if there's any concern for if there's any findings or in this subjective exam, they're describing any of these things, do you always think, okay, I should refer out for a second opinion? Or at what point, and maybe this is when we go into more of the red flags and the other screening and questions, but to what extent are we feeling comfortable continuing with just our own management and care versus when do we decide we need to refer out?
So how they broke it up in the paper was neurological versus musculoskeletal. And I think if you're not having any severe neurological symptoms present. And if you do like a quick neuro screen and there's nothing red flag wise going on, I think you're pretty safe to see how conservative care goes, but changing your conservative care in a way that is slower. And so that's important for everybody with hypermobility in general. A lot of the feedback I get is that physical therapy never worked for me. And a lot of the times it's because the timeline that physical therapy has for the general population is very different for the timeline in somebody with EDS. And so we naturally have slower healing times in general. We also take longer to build muscle. We take longer to build endurance. And so I think with cervical instability as well, not just accepting that these are what you have to deal with forever. I see that a lot too. That a lot of providers will be like, well, you have EDS and you have this, so this is kind of just your life. And yes, we can't cure EDS. Yes, we can't cure these things, but that doesn't mean we can't give somebody some hope and a better quality of life and giving them tools to help manage these things and make their life easier. Like just with low back pain or anything else, we try to create a tolerable starting point and gradually expose them. It's the same thing for this. It just so happens that this is affecting them in their everyday life in a way that like looking down might be debilitating for them. So things like prism glasses can be really, really helpful so they don't have to look down as much for right now. So little things like that can really go a long way. And so I really hate when providers are like, well, there's nothing we can do. Sorry. And you just have to deal with this. I don't even think I answered your question, but I just kind of went on a tangent.
No, you did. And let's go. So you mentioned the prism glasses, but I think we can dive into the intervention. So once an exam has been performed and we've ruled out in multiple red flags and we don't feel this immediate need to refer to a specialist or to someone else, how are you explaining this to a patient and obviously it's very patient dependent, but what does a normal discussion look like of this is a kind of what I'm seeing from this examination, and this is generally what we're looking at from a prognostic standpoint, and these are the potential options we have moving forward. Can you give a general example of what that discussion will look like? And then we can go into what are some potential interventions.
Yeah, definitely. And so I always say that I see like 3 types of different patients or clients. And usually I see more of, they already know they're hypermobile and they're coming to me because they want to manage this hypermobility. But before I started getting into coaching and I was in an in-person practice, I would have people come in for, let's say, neck pain and headaches and have no idea what hypermobility is. And your approach to explaining this to somebody that is not a part of this world and doesn't know what it is must be different than somebody who does, because it can be really scary if you're like, so you have a connective tissue disorder and now your whole life is about to change. Whereas when someone is coming to you and they already know that, it's a completely different discussion. So if I was to have somebody who knows they have hypermobility and they're looking into upper cervical instability, I would basically validate them and let them know that all of these things that you've been feeling, there's real answers for why. And there's some things that we can do to help make this better, which is really exciting. And I would kind of take it from that approach and explain to them that your brainstem may become compressed at certain times. And that's why you're feeling so dizzy. That's why you're getting so nauseous. That's why you are not feeling like you can function, or that you can't use your hands, and that you can't sit up straight, and that you can't keep your head upright. And there's a lot that we can do to help with that, which is exciting. If it was the opposite and it was somebody that had no idea what was going on, I don't love like the idea of creating urgency, especially from past chiropractic experiences. But in these situations, depending on how severe, there might be some modifications that we have to make. Like, let's say we have an athlete who is a CrossFitter and they are experiencing upper cervical instability and they're getting to the point where they might get neuro symptoms if they don't change something. That's when we do have to have those hard conversations and say, I know this sucks and it's going to be temporary, but we're going to have to slow down a little bit on your activities. We're going to have to make some changes in order to make sure that this doesn't get to the point where we may end up needing surgery. And so for whatever time period we decide for their goals, et cetera, we're going to do things a little bit different because there is true structural issues going on that we have to address before we can kind of get back to the things that we love.
So the paper gives actually a table 11, talking about interventions for all patients and interventions to avoid in high irritability patients. We can go into each one, but I'm curious your general thoughts on the interventions they proposed and if there is any actual solid evidence for these, or it's just these are potential options that may or may not help.
Yeah, definitely. And so, like I said, unfortunately, we really do not have evidence on any of this. So all of these who wrote this paper, they're part of the EDS Society. They're actually my mentors in the ECHO program. They're very active in this community, and they know this community better than, in my opinion, anybody else. And so when we don't have any research to go off of, that comes a point where we kind of have to create our own and go off of what we know. And so what this paper did is it allowed other people to start talking about this stuff and maybe get interested in it. And then we can really have some solid evidence. So if we're going to be talking about evidence, no, I don't think there is a lot of evidence on any of this, unfortunately. But I do think that in table 11, we can talk about the bolded word. So general education, I think that's great. I think that should be done for every single patient, no matter what is going on. Posture and body mechanics education. So this is where I don't want to say the word disagree, but don't 100% agree with. I think that especially the wording. So like I said before, if we tell a patient, hey, looking down is causing a lot of issues for you right now. It's not that looking down is bad. It's not that standing in that posture is bad, but for you right now, it's causing these problems. So let's maybe avoid that if we can for a little bit of time so we can calm things down and then build things up going forward. But I think it is important to know that there is no good or bad posture, and we know how that can be portrayed to the general population as well. So there is some nocibic language in the hypermobile community in general, because a lot of providers are really scared and they don't know what a hypermobile body can handle, and they do see them as fragile, unfortunately. And that is something I'm personally really trying to change. And so I think when we talk about posture in the way that it is spoken about in this paper, it can be a little bit nocibic, and I don't love that. So yeah, that's my thoughts on that piece. Pain science and self-care. So this is actually a conversation I have a lot. And we talk about how in the general population, most patients don't want to hear about pain science and learn about these things. They just want to get better. From my own personal experience, the patients who have been through the system and who are trying to look into these things, they have been thrown around so much. They want to know these things. They want to know what's going on in their body. They want to know why they have not felt normal in years or their whole life. And so that is one big difference I do see in this population, is that they actually do. They want to have these conversations with you. They want to know why these are happening. And sometimes that's a hard conversation for me. And I have to explain to them, before we think about the why, let's start working on the how and how we can feel better and how we can get some relief. Because if we're only focused on why this is going on, we may never feel better. And we also may never know the answer to that. And so that is a conversation I do have a lot. Neck bracing. So neck bracing, I actually do use, and I think it's really important for this population. And I think as physical therapists and as chiropractors or anybody in an MSK setting, bracing has a very stigmatized thing right now. And bracing is not always bad if it's used correctly. And when a neck brace allows you to drive in a car and you can't drive without one, it's useful. It's creating independence. It's allowing you to do the things you want to do. Sure, is it creating a little bit of muscles not getting stronger, okay, but I'm allowed to drive now and I'm okay with that. And so making sure that your patient knows you can't wear your brace 24/7 and we have to do strengthening exercises when we take it off and we have to only wear it for a certain amount of times. But I want you to use this brace to your advantage. Use it for the things that you can't do. So for instance, even with lifting, I have a patient right now who, if doesn't have her neck supported, she can't really do a lot because she's going to pass out. And so we put the neck brace on and now she's able to squat. And so things like that, allowing you to do the things that you want to do, I don't see a problem with that. I also think it's a good thing for diagnosis for upper cervical instability. Like I said, if you have somebody who's super severe and you don't want to do a physical exam on them, having the neck brace on, and if that reduces their symptoms, there's a much more likely chance that they are dealing with this. And so that's a really good kind of screening tool, if you will.
I have a question too.
Yeah, what's up?
So the bracing, is it how specific do your recommendations get? Do you say, find whether it's soft or rigid or something in between that you feel like is reducing your symptoms? And do you start at the least restrictive? How does that conversation generally go?
Yeah, definitely. And so I actually like to start with a soft collar because you can drive in a soft collar. You can't drive in a hard collar. It's illegal to drive in a hard collar. And so if a soft collar is helpful for their symptoms, that's what I start with always. A lot of people also in this population have a lot of sensory issues. And personally, I deal with this as well. If I put a soft collar on, like it makes me want to throw up. Like it does not feel good. And so that's something to be aware of, and asking your patient, have you dealt with any sensory issues? And people in this population do know what that means. And then, so if they can't handle the soft collar, I will go to a hard collar, and I try to go like least stable first to most stable. So there's ones where it will hold your jaw up. That's like my last resort. Whereas the ones that don't hold your jaw up are kind of my first. And there's a bunch of different types of braces and things like that. So as far as that conversation goes, I like to have the patient hopefully be able to try some on before they purchase one. That's ideal, not always possible. So when that's not possible, I ask a bunch of questions about basically like, what do you normally like? Like, do you like wearing collars? Do you like having things around your neck? Does that bother you? When your neck is in a stable position and you do feel okay. So like when you're doing it yourself and you're putting a pillow for comfort, where is that pillow? Is it higher up? Is it lower down? Those are going to be some questions I'm going to ask to try to figure out what's going to be the best brace for them. But that's a very individualized question.
Thank you. That helps. Yeah. That helps. Next one, manual therapy.
Manual therapy. So as I said before, I am a chiropractor. I went to chiropractic school. I've been adjusted. I was adjusted every single day. I don't know how many times for 2.5 years, because then COVID happened, for 2.5 years. And I did not really care about my hypermobility then, because like I said, I was fine. I started getting adjusted a lot, especially in my neck. And I truly have never experienced that type of pain and those types of symptoms before. And so I ended up getting neurological symptoms that were really, really scary, and severe, severe neck pain. And so in my opinion, I think if you have a hypermobile person, rule out upper cervical instability before you adjust their neck, or just don't adjust their neck at all, because let's be honest, you can do so many other things to give somebody relief besides a neck adjustment. As far as soft tissue and things like that go, I think that there is value in short-term relief, especially for this population where things like pain medications don't usually react well with their body or don't work at all. And so having something for short-term relief can be really, really valuable and really beneficial if you know that's why you're going there. I find in this population that the word alignment and the word adjusting mean different things than in the general population. And so we do deal with true medical subluxations, and that can get really confusing when chiropractors are talking about subluxations. They're not the same thing. So a medical subluxation is when your joint partially dislocates and comes back in. And that is something that most of us deal with on a daily basis. That is very different than, I don't even actually know what a chiropractic subluxation is, and I'm a chiropractor, so like I'm not even going to define it because I genuinely don't know what that is. But if someone is telling you that they can align you or put your bones back in your spine with their hands, they can't. And even with a subluxation, you don't need a chiropractor to put that back. For a full dislocation, that's a completely different story. You do need medical attention for that. And usually I would recommend going to the ER for that over going to a chiropractor, because we're not taught to do that in school, if I'm being completely honest. And so as far as manual therapy goes in general, like I said, I think that there is benefit to it for short-term relief for some people sometimes. And I think that for the general population as well. And I don't think it's much different for this population, except for the fact that they are a little bit more resistant to pain medication. And I think that's important to note. Yeah. And then the next one is motor control. So we were going to talk about this anyways. Yeah, I believe so. Motor control and proprioception, I think, kind of get like used as the same in this paper. And so what proprioception is like where your body is in space. And when it comes to the neck, a lot of hypermobile bodies, me included, like if you ask me to go through my range of motion, my neck's going to be all the way over here, and I'm not going to actually realize that it's all the way over here. Like I don't feel that it's more range of motion than it should be. And for proprioceptive exercises and gaining that like awareness of where your body is in space, I know, Chris, we talked about this a little bit on our last podcast. And I have a different opinion now than I did then. So I don't know if you want to get into that now or wait a little bit.
Yeah, we might as well. So I guess we can initially talk about what your opinion was about 6 months ago and how it's changed.
Yeah. So about 6 months ago, I was doing a lot of like propriopad, Bosu ball, those types of stuff. I see Sam rolling his eyes, those types of stuff. And honestly, I was doing that because it helped me. And I didn't really look into why I thought it helped me. I kind of just like, oh, it's proprioception. That's why. And now looking back, the reason it helped me so much is because it actually just gave me feedback to allow me to do things easier. And so like the Bosu ball for, I'm going to use squats or pistol squats as an example. It's easier for me to do it on a Bosu ball because I'm getting feedback. It's not actually gaining my proprioception. It's just making that movement easier. And so that I'm able to do it better. And now I'm more aware that proprioception is more about different sensations and taking away maybe your eyes, closing your eyes, or even sound and things like that. And that's a much better way of gaining proprioception over time.
Solid. So has that changed how you program and recommend for patients from a motor control or proprioceptive standpoint?
Yeah, definitely. So I no longer have any of my clients doing propriopad or anything like that. So now with proprioception, I try to just make it more of like an everyday activity and like them allowing it to be a part of their everyday life. So when you're brushing your teeth, close your eyes or stand on one leg. And when you're making coffee, start thinking about these things slowly. And this is more for like full body proprioception. And in this population, patients do lack proprioception. We do know that. And that's why we're considered more clumsy. And you may find yourself like walking into things more and just feeling off, not being able to walk in a straight line a lot, things like that. And as far as upper cervical instability goes with proprioception, it's a little bit different. And I do like to use like mirror stuff so that you can really like see where your neck is. And then the laser stuff I do still use. I do think it's beneficial because I think it's a good way for patients to actually see where they're trying to go to get to that target. And I think it's a good cue for them.
Any other thoughts on motor control, or do you want to dive into aerobic exercise?
I think Sam has a question.
Oh, yeah.
Yeah, two questions. On the laser, can you clarify how you use that?
Yeah, so like a headband laser target and basically having patients doing some sort of exercise, and I want you to keep that laser in the middle of that target, or sometimes I want you to keep that laser at the top of the target, etc., things like that.
Okay, that makes sense. And then when you were saying, like for yourself, when you do exercise with the Bosu ball, you feel more feedback. Like, what do you mean by that?
Yeah, so I think also with the Bosu ball, you do get more plantar flexion, which allows you to get into a pistol squat much, much easier. But as far as feedback goes, like when I'm just standing on the Bosu ball, it's shaking, it's wobbling. So I have to almost use my muscles in a way where I don't have to on the floor. And it's giving me that feedback in my brain where I'm like, okay, I have to stay balanced. And I know what balance means, because if I go more to the right, the Bosu ball is going to tilt to the right. Whereas I don't have that feedback on the floor.
Yeah, I don't I don't think anyone could really argue with that. I think the first point that you made about the plantar flexion is huge, with particularly movements like any sort of squat oriented exercise. I know for myself, I don't have the most fantastic dorsiflexion. And so if I try to do a flat ground pistol squat, I'm going to struggle. Whereas if I'm in a weightlifting shoe or on a Bosu ball, I can pump them out. But the other factor of, like, if you are on the flat ground and you are descending down, you're going to be obviously maintaining relative positioning. Whereas if you're on a Bosu ball, you're going to get feedback because you're falling. So exactly. You do in fact have more input. Yeah, I don't think those are detriments to it. It's just about, like, what's the purpose and intent that you have with that.
Exactly. And so I also have a cheerleading background, and we used Bosu balls extensively to train body positions. And when I stopped cheering, I just used Bosu balls in kind of my workout routines, because that's what I was used to. That's what I did. And I got one of my videos blew up, and everyone was like, that's so dangerous. Like, what are you doing? And I was like, well, it's actually just making it easier. And so I think we're very quick to be like, why are you doing that? And sometimes it's because it's easier and I'm able to get those reps in, and it's building my confidence. And now I'm able to do that skill because I had those reps that I wasn't going to get without it.
Boom. All right. Let's go aerobic exercise, then interventions to quote unquote avoid with high irritability patients.
Yeah. So aerobic exercise, this has more to deal with the comorbidities that come with UCI and HEDS than I think UCI itself, kind of. But like we said before, some people can't do a lot unless their neck is supported. And so a recumbent bike is a really easy way to get your full body supported. And then I'll have patients walk on a treadmill with their neck brace on because they can't walk without it right now. And so I'd rather get you walking with your neck brace than not walking at all. And as far as, I think that's all they said was recumbent bike. Yeah. So that's my opinion on that. In my opinion, with POTS and with dysautonomia in general, I think we are a little bit too quick to assume that patients aren't able to do certain things, and we put them on a recumbent bike right away. And a lot of the time it's athletes who are very, very capable of holding themselves up, and we put them on a recumbent bike and make them feel very, very fragile because of that. So I think we need to be a little bit careful when we do that as well. Anything on that? As far as interventions to avoid, exercises involving moderate to large neck movements, such as cervical range of motion. So this is very patient to patient dependent. If your patient can't handle looking down, they're not going to be able to handle, exercises with large neck movements. I can't even really think of any off the top of my head, but it says in here chin tucks. I find most patients can handle chin tucks, but if you find your patient can't handle chin tucks, don't give them chin tucks. I think that's just patient to patient. Cervical axial loading or distraction. So traction is contraindicated in cervical instability patients. So that includes the Y strap. That includes taking a towel and pulling. That includes those decompression tables that chiropractors love to use. And it's really important that chiropractors know this, because I've seen this so much. They come in, they say they have upper cervical instability. The first thing they want to do is traction. They give them an at-home traction unit. It's like, what are we doing? What are we doing? So that I do totally agree with. It's contraindicated for a reason. And it makes sense. If you're pulling on somebody's head who's unstable, it's not going to be a good thing. It's not going to go well. And so that's my opinion on that. Only therapists with UCI expertise should perform any manual therapy on the cervical spine. I think the reason they put that in there is mainly for chiropractors to not adjust on upper cervical instability. Manual therapy doesn't need to be specific. We know that. I think that they're trying to get their message across that chiropractors who don't know this, please stop. And positioning that creates neural tension, pelvic tilt in some people, or isometric load to the cervical spine. So I'm not sure what positioning creates neural tension, what they meant by that. I don't know if you know what they meant by that. Yeah, I'm not sure on that, but I think if a position is causing symptoms, modify that position until it doesn't, and then build them up until they can handle it.
Sweet. So overall, we kind of covered the majority of the paper. What are things that you think they could have done better? What are things you really like about the paper? And then I say we move into the next topic of medical gaslighting.
Yeah. So I really, like I said, I really did like this paper because it was the first one that even discussed this. And so there has to be a first. And I think they did a really good job at talking about red flags, talking about yellow flags, talking about the importance of a history, talking about the importance of listening, talking about the issues with diagnosing this and how hard it is to get a diagnosis for this and why it's so hard. And I thought they did a good job at showing the severity that it can be, but also emphasizing that that's usually about 5% and that's not going to be the majority. I think things that they could have done better, and this is just kind of my own personal opinion, and it's going to kind of get into that over medicalization, is defining things like posture and forward head carriage and some of these outdated terms that we now know are outdated. I wish they left those out. But I don't know that physical therapy as a whole, or chiropractic or musculoskeletal care, whatever you want to call it, as a whole, I think we live in a bubble where we think that most people don't use these terms, but I think most people do still use these terms, unfortunately. And so that goes into my next topic with medical gaslighting. With this condition specifically, with upper cervical instability, it mimics a lot of other things, including anxiety. And I can't tell you how many times I've had clients and patients come to me and say, I've been to so many different doctors. They've done brain scans on me. They found nothing. I've gotten an MRI on my neck. They found nothing. And that's because they're not looking for upper cervical instability. The only thing that can detect it is a dynamic X-ray or an upright MRI. And so patients are so confused why they're not functioning. And every doctor is telling them, oh, it's probably just anxiety. Like, take some meds, you'll be okay. And that's not okay. We have to do better than that. We have to. And that's a big issue. And then on top of that, you say you have EDS, and now all of a sudden EDS is kind of a trigger word for doctors because it's all over social media these days. And they're like, oh, the TikTok disease, you're fine. This is just something you have to deal with. That's not okay either. And then with that, with over medicalization, I think this is a good example, this paper, like talking about forward head carriage, talking about upper cross syndrome, talking about these things that we know don't really matter. That's a problem in this population as well. And there's also under medicalization in this population as well. And so it is kind of a fine line. And a lot of patients get very confused because they're like, what does actually matter? Like, does my pelvic piriformis syndrome versus my POTS, like, which one is real? Because we do make it more confusing by saying, like, this isn't real, this is real. And I think as a whole, we can all be better on getting on the same page, but I think that's going to take a long time. Yeah,
to the sheer amount of potential signs and symptoms and day-to-day disturbances a patient like this may have, they are probably bombarded with information. And how do you decide what is factual versus maybe not so factual. And then even for clinicians, it's hard a lot of times. And even, I don't think we really addressed it here, but our last talk, the Beighton score, it's like even clinicians still utilize that, but is it even that valid? So it's so messy. And off that point, I'm curious because I think we talked about this 6 months ago because I was still working on that fibromyalgia piece then, and I still haven't finished it. But there's there's things like fibromyalgia and either functional neurological disorder, or it used to be called conversion disorder. There's these that I feel like tend to be bucketed into, there's a lot of layers and a lot of prior history of other like psychosocial events and trauma. Do you feel like EDS and hypermobility gets bucketed into those classifications as well, where there's not a lot of great diagnostic criteria? People end up kind of like anchoring themselves to this diagnosis. What are your overall thoughts there?
Yeah, I do. I think it's bucketed in that realm, especially in clinicians as well, not only just in patients and clients, but also with that being said, I'm very curious, once the gene comes out, are we going to think differently about HEDS and hypermobility? I have a feeling we will, which is very, very interesting. And EDS in general is so rare that unfortunately it wasn't talked about before, but now we know HEDS is not rare. It's extremely, extremely common. And now that we have that knowledge, I think more people are going to start to care about it, and they're going to start looking at it a little bit different. And as far as we know, pain in general, chronic pain, which is what this population is dealing with, it's multifactorial, it's biopsychosocial. So there is there's a psychological component to it. There's also a biological component to it. And we have to consider all three of those. And I actually think the social impact of this is more like not talked about enough either. A lot of people with HEDS, people don't understand them. Their friends don't understand them. They don't know why that they can't stand at a party for more than an hour. They don't know why they're getting so dizzy. They don't know why their friends aren't how they used to be. And we now know there's a lot of different connections with neurodivergence and autism and ADHD. And there's all of this stuff that's kind of making sense slowly, but it's going to be a slow process. So I think we have to be open-minded a little bit as clinicians. And this kind of goes into the territory of like, there is no evidence on this. There is no research on this. So we do have to kind of use what we have out there, but also use our common sense and just listen to the patient in front of you. If a patient is telling you that they're in pain, patient is telling you that they don't feel well, patient's telling you that they're going through these things, instead of trying to be like, what is this? What could this possibly be? Oh, it's anxiety. That makes so much sense. Why don't we just say, I understand you're going through something that is really, really hard right now. Let's try to make it easier. Let's not even worry about all these logistics right now. Let's just get you feeling a little bit better, because that's what you're here for. That's what you want. So, yeah.
With this, take a step back. You mentioned a lot of upper extremity and upper cervical symptoms that individuals experience. Are like sciatica type symptoms or anything like that common as well?
Yeah. So the craziest thing and the biggest thing, and this is why a lot of patients fail physical therapy, is that it affects every single part of your body. So you really have to take a full body approach. And when you're going to physical therapy, for example, for hip dysplasia, and they're only focusing on your hip, but you have extreme neck pain, you have to address everything in order to get the hip to feel better, in my opinion. So I think that is one of the limitations, especially in an insurance-based practice, that I see a lot. And a lot of these patients say, like, yes, I've tried physical therapy so many times and it never worked. And I think a lot of that has to do with the fact that their physical therapists aren't used to having a patient with so many issues at once.
Yeah, I have a virtual client or someone that I did 2 consultations with, and they were given a diagnosis of scan negative cauda-equina syndrome, but they're a previous high-level swimmer and gymnast and have extreme mobility. And I never thought about it being related to something like this. They don't report any neck or upper body symptoms, but they have basically every cauda-equina syndrome to a low level. But they've been scanned in every possible format and all negative. Because there is a diagnosis of scan negative cardiac Winans syndrome, but there's no real treatment, no real information on it. So it sounds in a lot of ways similar.
Yeah. Have you looked into tethered cord syndrome at all?
No.
I would definitely look into that. It's just a possibility.
I will check that out.
All right. Any more thoughts on overdiagnosis or over-medicalization, under-medicalization?
Yeah, I do want to mention one thing, especially with the word subluxation, like we talked about before, and alignment and those things. And I do think that as chiropractors specifically, we have to stop trying to create this thing, because in my opinion, that is over-medicalization, and telling hypermobile bodies that their spines are subluxing. They genuinely think it's the same as their shoulder that does sublux, and they believe that their spine is going in and out of place. And that's so scary. Like, imagine walking around thinking your spine is going in and out of place all of the time. So please be careful with your words when you are discussing these things. Define them for your patients. Explain to them what's going on in your shoulder is your joint is going in and out sometimes, and you know what that feels like. That is different than what's going on in your back. Explain these things. It's important.
So what about more broadly hypermobility and HEDS with your recommendations and your experiences with strength training and just graded exposure to heavier loads? What have you found? What do you recommend with patients?
So the biggest thing, and I don't even think I said this yet, but when I was 18, I went to an Orange Theory class and I was doing tricep extensions. And the trainer came up to me and was like, you need to put that weight down. You need to go to a doctor immediately. You need to never lift weights again. I was 18. I didn't know any better. I didn't know any of this stuff. And so, Sam, to give you some context, my shoulders dislocate anytime they go overhead or sublux. So they go in and out a lot. So this personal trainer obviously has never seen anything like that. And so I went to a doctor on campus, and they basically confirmed, a physical therapist confirmed, like, yeah, don't lift weights ever again. Like, do not train. And I listened. I didn't know any better. And those 2 years that I listened were horrible. They were just horrible. I didn't enjoy my life. I didn't feel good about myself. I was in more pain because of it, et cetera, et cetera. And so now that I know strength training is so beneficial to this population, it kills me that happens, and it's still happening. There are still physical therapists and chiropractors telling hypermobile bodies that they can't lift weights because it's too dangerous. And there's been this like new uptake in Pilates in the hypermobility world, whereas Pilates is like the best exercise for hypermobile bodies. And every single client I've had has been recommended to do Pilates. I swear, I don't know, the past 3 months, if I've heard the word Pilates so many times, I can't even tell you. And I think the reason for that is because it's slow movement and it's a lot of supported movement. So you're laying down a lot, you're sitting down a lot, your neck is supported, and that's great. But we can use strength training in a supported way if needed. And not every hypermobile body needs that level of support. And I think it's really important that you don't generalize everybody. It's a spectrum. Some people are going to be able to handle a lot more than others, and that's okay. And we're all going to have different starting points. And I think also you're getting high-level gymnasts who are dealing with this. You're getting high-level dancers. How are you going to tell them that it's too dangerous for them to lift weights, yet they can go do a double back? Like, it doesn't logically make sense. And at the time, I was an elite tumbler. Like, I was an elite tumbler at the time, and they were telling me it was too dangerous for me to lift weights. And so as far as strength training goes now, obviously we know it's super beneficial for so many different reasons, for confidence building, for feeling strong. There's so much power in feeling strong, especially when you have been told you're fragile your whole life. And now all of a sudden you're able to do things you couldn't do before. It's huge. It's game changing. It's life changing. And with strength training, like everything else, start where they're at, meet your patient where they're at, gradually go up. Things don't go the way you want them to, change them. But the one thing I will say with strength training in a physical therapy setting, or in general with hypermobile bodies, is it's going to take more time. And so what I find a lot is that physical therapists want to push their patients, and which is good, but being aware that pushing a hypermobile body to the speed that you want them to go at is not going to work well for them. You have to go at their speed, and it might be slower than you think. Get comfortable with that, because it might feel like you're not making a lot of progress. Zoom out big picture, you are, and realize that this is going to be slower than what I'm used to.
Yeah, that's great. So are there, besides the current fad or trend of hard Pilates recommendations, what other things have you noticed become really trendy recently that you maybe want to either debunk or add more nuance to?
Yeah, so yoga, and really any movement. Yoga is like the devil in this population because it's stretching. First of all, you can stretch if you're hypermobile. You can still be tight if you're hypermobile. If you enjoy stretching, you can still stretch. You don't want to overstretch, and that is something in the gymnastics and cheerleading world. So overstretching is when you're putting like blocks under your feet and being pushed down to gain more range of motion. That I would recommend staying away from in hypermobile bodies. They also don't need it. They have the general range of motion anyways. And with that being said, so like yoga, a lot of people are told you can never do yoga again. And a lot of people really enjoy yoga, not only physically, but mentally as well. And there's no reason you can't do yoga. You might have to make some modifications. You might not be able to do all the poses or hold them for as long as everybody else, but learning those modifications and making them work for you can be really fun and beneficial and allow you to continue to do the activity you love. And I think that that's the approach we should take for any and all exercise when it comes general population too, but especially in this population when they're told they can't do so much. How about we ask ourselves, how can I get them to be able to do this right now, and so that they can do it long term?
What else? What other trends have you noticed?
So like I was kind of hinted at before, hypermobility is blowing up on TikTok recently, and so is POTS. And POTS is now being seen like in the media, which is so, so awesome. I think CNN did something on it. I know that there's a bunch of celebrities coming out on it. And with POTS, it's now being talked about more because it's very common with long COVID. But I think it's going to start being talked about more because it is seen so much with hypermobility. But one thing I see with POTS, and kind of like a myth, if you will, is that POTS is the only type of dysautonomia. There is, I don't know how many exactly, but over 10 different types of dysautonomia. POTS is not the only type of dysautonomia, and you do not have to have POTS and mast cell activation syndrome in order to have HEDS. I think that's important to say as well. And you can have a different type of dysautonomia and have EDS. So personally, I have orthostatic, now they're calling it orthostatic hypotension. I was orthostatic intolerance like a couple of years ago. Everything's always changing. And so that's still type of dysautonomia. And I think POTS is just being talked about the most because it is becoming very, very common, especially with long COVID. And then as far as other kind of myths and trends and things like that, like I talked about, neck adjustments, don't get them. It's just not worth it. It's just really, really not. There's so many other things that you can do to get the same exact results. And if you're hoping that a neck adjustment is going to put your bones into place or into alignment, it's not. And I'm a chiropractor, and I will be the first to tell you that. So there's that. Yeah, what's up?
You had mentioned the gene that they should be finding soon. Is that correct? Or that's going to create clarity for HEDS in particular. Is that correct?
Correct. Yeah.
Are there any, I guess one, is the benefit there, patients coming to you with this certain presentation and they may get the gene and now they know, is there any downside for that to occur, like that much access? Because I guess you could see genes for multiple things, that this may go into the kind of over medicalization standpoint. What are your thoughts there?
Totally. And so I've actually really been thinking about this a lot. Like there's obviously so many benefits. And in my opinion, the benefits to finding the gene completely outweigh the negatives, because it's going to prevent medical gaslighting a lot for a lot of people. So a lot of people right now, they go and they think they have HEDS, they have all the symptoms, they pass the diagnostic criteria, and then their doctor's like, well, I can't diagnose that because there is no like real diagnostic criteria. And they're not wrong. It's not, the diagnostic criteria we have right now is not scientifically proven. It hasn't gone through clinical studies. There's no validity to it. There's no specificity, sensitivity, like none. So they're not totally wrong, unfortunately. And so when we have this gene, they can no longer use that as an excuse. So that in itself is extremely valuable. And also for patients who self-gaslight themselves too, like, do I really have this? Because some doctors say it doesn't even exist or it doesn't even matter. And so now they have a way of showing, oh, okay, yeah, I do have this. This is what I'm dealing with. I can now work on this. And there are a lot of people, and I think this is more of like a personality type. And I think personality types really, really matter and care. And I think there is a personality type that's like, I need to know what I have in order for me to do something about it. And I'm going to keep searching until I know. And I think that's a personality type. And I think those people are hard to kind of figure things out with together. And so this is going to be very beneficial for that population. But as far as negatives, yes, I think there are negatives to everything. I think there's going to be people who don't have the gene, who were diagnosed with HEDS or who think they have HEDS, and then they're going to be wanting to search for more and more and more. And then there's also epigenetics. There's a whole talk about that and how is that going to affect this, and then the over medicalization of it. If you don't have any symptoms and then you get this diagnosis, and now this diagnosis dictates your life, but you weren't even symptomatic before. So totally.
Is there, to that point of being asymptomatic, there in the paper, it talks about symptomatic GJH or versus asymptomatic, but generally is there research around base rates of people who have this? Well, I guess it's different because they're trying to look for a diagnosis and they're probably symptomatic. So they're probably not able to do these studies yet of finding how many people have HEDS that aren't symptomatic. I might have just answered my own question.
For the diagnostic criteria, and they're basically, you have to pass the diagnostic criteria to be involved in the study that they're doing at the Norris lab. And for the diagnostic criteria, you have to be symptomatic. So yeah.
Makes sense. Any other final thoughts or things you feel like we didn't address based off of like the topics we wanted to cover?
I think we addressed a lot. I would say final thoughts just for anyone in an MSK setting: listen to your patients when they're telling you that they're feeling things that you might not understand. Ask more questions. Ask people. There's a lot of people who do know about this now that didn't before, and they're all over social media. So reach out. I'm always, always, always happy to help anybody trying to figure out anything in this realm. I think it's really important that we just start talking about this more because it's not talked about enough.
What, besides your information and that stuff you're putting out, are there resources that you'd recommend for clinicians to utilize if they have these patients that they're working with?
Yeah, so the EDS Society is a great place. They have an ECHO program, which is basically, I think it's $20 per session. And it's just talking about this stuff that we just talked about and talking about different practitioner opinions and things like that. I just recently did a POTS course with Emily Richot, and it was amazing. Highly, highly recommend. She's an occupational therapist who specializes in POTS. She's a great resource for POTS in general. And then as far as other resources, there's a couple of blogs that are really good. I think I'm a pretty good resource as well. And yeah, I would say those are the main resources right now.
Awesome. Sam, any other final thoughts or questions before we wrap it up?
No, that was fantastic. Thank you very much.
Yeah, thank you so much, Taylor.
Awesome.